Alright, let's talk about Rinne's test. Rinne's test is one of those ENT topics that look simple, but if you don't understand it, it becomes confusing very fast. Once you get the logic behind Rinne's test, you will never mix it up again. So, definition. First, what exactly is Rinne's test? Rinne's test is a tuning fork test used to compare air conduction AC and bone conduction BC of sound in each ear separately. It helps in the assessment of hearing loss. In short, we are asking one simple question: does sound travel better through air or through bone in this ear? Now, principle. Normally, air conduction is better than bone conduction because sound waves are amplified by the external and middle ear. Normal ear has air conduction better than bone conduction, meaning Rinne positive. Now this means in a normal ear, sound reaches the inner ear better through air than through bone. Why? Because sound gets amplified by the external ear and middle ear. So remember this, in normal ear, air conduction is better than bone conduction. That is called Rinne positive, AC greater than BC. Instrument used. We use tuning forks of 256, 512, 1024 Hz, but in real life and in exams, 512 Hz tuning fork is preferred. Why? Because of minimal overtones. If we hit a bell, we want to hear one clean sound, but sometimes the bell makes extra tiny sounds mixed in, and those extra unwanted sounds are called overtones. 512 Hz has very few overtones, so the sound is clean and pure. It has good balance between vibration time and clarity. Now 256 Hz vibrates too long, so patient gets confused, and 1024 Hz vibrates too short, so sound disappears quickly. But 512 Hz is just right, not too long, not too short, and easy for the patient to tell when the sound stops. Now 512 Hz fork shows slow decay, meaning sound fades smoothly cause decay means how fast the sound dies out. So the patient can clearly say, yes, now it stopped, and yes, I hear it again. So which tuning fork is preferred for Rinne's test? Answer is 512 Hz tuning fork. Now procedure. Now let's actually do the test. Strike the tuning fork and place it on the mastoid process. This checks bone conduction. Second, ask the patient to tell when the sound stops. The moment they say, I can't hear it, move the tuning fork close to the external auditory meatus. This checks air conduction. Step 4, ask, can you hear it again? That is it. Simple. Now, interpretation of results. This is the most important part, interpreting the result. Rinne positive, AC greater than BC. This is seen in normal hearing and sensory neural hearing loss. Yes, sensory neural loss still gives Rinne positive. Don't get tricked. Sensory neural hearing loss means the sound conduction pathway is normal, but the problem is in the inner ear or nerve. So in sensory neural loss, both AC and BC are reduced equally, but AC is still better than BC. So the relationship remains the same and we get Rinne positive. Then second, Rinne negative, BC greater than AC. This means conductive hearing loss. And remember one point, a minimum air-bone gap of 15 to 20 decibel is needed for Rinne to turn negative. Now what does air-bone gap mean? So it is a difference between air conduction and bone conduction hearing levels. In simple words, how much better bone hearing is compared to air hearing, and this air-bone gap is seen in conductive hearing loss. Air-bone gap is not present in normal ear or sensory neural hearing loss. Then false negative Rinne. A false negative Rinne occurs in severe unilateral sensory neural hearing loss. Severe unilateral sensory neural hearing loss. So a false negative Rinne means the test appears Rinne negative, BC greater than AC, but the patient actually had sensory neural hearing loss, not conductive loss. So the test is misleading. To understand the logic behind this, let's say a patient has unilateral sensory neural hearing loss and that patient's right ear is damaged and left ear is normal. Now during the Rinne's test of damaged right ear, we put tuning fork on the mastoid behind right ear. Bone vibrations will travel through the skull and they will be heard by the opposite normal ear. This is called crossover hearing. And patient says, yes, I can hear it. But the sound is actually heard by the opposite normal ear, not the tested ear. But when we bring tuning fork near ear canal of the same damaged right ear to check air conduction, air conducted sound does not cross easily. The damaged right ear cannot hear it. So the patient says, no, I can't hear it. So examiner gets the final result BC greater than AC, which looks like Rinne negative. But of course it is a false negative. Now predicting air-bone gap. Now this means using Rinne's test with different tuning forks. We roughly guess how big the conductive hearing loss is. Before we learn how to predict air-bone gap, remember low frequency tuning forks such as 256 Hz are easier to hear by bone and high frequency such as 1024 Hz need better air conduction. So smaller air-bone gap affects low frequencies first and larger air-bone gap affects even higher frequencies. Now the three predictions. First, Rinne equal or negative for 256 Hz but positive for 512 Hz means AB gap 20 to 30 decibel, meaning bone conduction is slightly better than air conduction only at low frequency. At higher frequency of 512 Hz, air conduction is still better. This means mild conductive loss. Predicted air-bone gap here is 20 to 30 decibel. Remember, when only the weakest fork is affected, there is a small gap. Then second, Rinne negative at 256 Hz and 512 Hz but positive for 1024 Hz. AB gap of 30 to 45 decibel is predicted. Meaning conductive block is worse here. Even 512 Hz air conduction is affected. But very high frequency 1024 Hz still passes better through air. This means moderate conductive loss. Predicted air-bone gap here is 30 to 45 decibels. Remember, if two forks failed, there is a bigger gap. Now third is Rinne negative for 256, 512, 1024 Hz. AB gap predicted here is 45 to 60 decibel, meaning air conduction is badly blocked at all frequencies. Bone conduction is clearly better everywhere. This means severe conductive hearing loss. Predicted air-bone gap here is 45 to 60 decibel. Remember, if all forks failed, then there is a larger gap. One simple trick to memorize this is more the forks negative, bigger the air-bone gap. One fork negative, small gap. Two forks negative, moderate gap. Three forks negative, largest gap. Now this is not for diagnosis, it is just a rough estimation. So why do we even do Rinne's test? Its clinical significance. Because it differentiates conductive versus sensory neural hearing loss. It is quick and bedside friendly. It must be interpreted along with Weber's test. It works well as a screening test in OPD and wards. Now, limitations of Rinne's test. It is not a quantitative test. It is less reliable in mixed hearing loss. It depends on patient cooperation. So never rely on Rinne alone. To sum up, Rinne's test is simple, fast and extremely useful when you understand the logic behind it. If you remember just one thing, remember this. Normal ear has air conduction greater than bone conduction, meaning Rinne positive. That's it. Understand the principle, not just the pattern, so this topic becomes easy. If this explanation helped you, revise it once before exams by rewatching this video and try correlating it with Weber's test. I will see you in the next video.